CRED infection now is the rate globally is around 0.5 to 6%. The exact figures are not really known because the standardization for studies, but for instance, the predisposing factors can be classified into host-related, procedure-related, and device-related. The most important and the preventable measure is the procedure-related. Okay, so the most important thing before the procedure is to follow the guidelines giving antibiotic prophylaxis 1 hour before the procedure, experienced operator, and also to secure the post-operative hematoma. Some operators just suffice doing the manual stopping of the bleeders and neglect the use of the diathermy. This is very important because afterwards the post-operative hematoma invites infection. Also, the rate of the post-implant infection is doubled if you increase your procedure, if you have to re-intervene for lead dislodgement or pocket revision by 2 times. Host-related issues like diabetes mellitus, renal failure, history of device infection, malignancy, heart failure, steroid use, or anticoagulant use, which might cause also an hematoma and invite infection. Less common issues like device-related, if you have to put your pacemaker into an abdominal pocket, the more leads you have, the more infection you get, and the epicardial leads. Once your lead is intravascular, after 1 week, the endothelial lining begins to envelop the whole intravascular part of the lead. This has a benefit. Later, it prevents the later bacterial seeding of your device, but becomes a headache afterwards if you want to extract the lead, because also it invites fibrosis. We can see here that the most common sites for fibrosis are the superior vena cava, nominate vein, and the intracardiac portion. It varies between patients, but depends also upon the implant time, the presence of a dual coil ICD leads, and the passive fixation lead. So we now opt to use active fixation and ventricular leads and single coil ICD leads, or the newly developed coil like drug-eluted coil leads. About more than 70% of the microbacteria that causes the pacemaker infection are staph, the coagulase negative staph, and penicillin sensitive Staph aureus, and now emerging MRSA. Less commonly, we can see a gram-negative bacilli or even fungal in immunocompromised patients. We can divide the clinical presentation according to 2 categories. If you have what we call superficial or generator pocket infection, the most common that we see, or the deep lead infection. It could be associated with valve infection as well. In this case, we call it pacemaker endocarditis. Pocket infection can be possibly done early, within the first 30 days post-implant. It's usually easy to recognize because it's associated with systemic manifestations, fever, chills, and it's easy to recognize erythema, swelling, sinus discharging pus, or swelling, thinning of your pocket. Or it could appear later, 3 to 6 months after implant. And this could be hard to recognize because sometimes it's only manifested with indolent symptoms like weight loss, or you can never differentiate it between trauma to the pocket or whatever. It has minimal changes, but it will lead to all that we know, that the thinning of the pocket, erosion, and pocket pacemaker or lead erosion outside the pocket. Concerning the lead infection, also 1/3 of the cases occurred in the first 6 months, associated as well with systemic symptoms, and is usually associated with generator pocket infection. The other 2/3 can occur 3 to 6 months after implant, average duration 25 months, and the symptoms are usually, as we told before, protein or indolent, resulting in delayed diagnosis. Usually it's a right-sided endocarditis. Sometimes you can see left-sided, it's not so common. It's important to recognize that because we have seen a 70-year-old female patient who came with us to fulminant chest infection and sepsis with the TE, and we found a vegetation on the ventricular lead. The whole case was a pacemaker infection, and she fortunately passed away. To make the diagnosis simple, if you compare it to infective endocarditis, blood culture, imaging, TE. The blood culture is the usual 3 sets of culture. Unless your patient has sepsis or septic shock, you can opt to make 3 sets of blood cultures, 1 to 6 hours apart. But once your patient has severe sepsis, it's important to start antibiotics in the first hour because after 60 minutes the mortality rate increases. If your cultures are negative, or if you cannot do blood cultures, usually we use, once you extract and explant the system, tissue culture or a lead tip. Echocardiography is, according to the guidelines, TE should be performed in all patients with suspected device infection. The TE is more superior, but you have to know that it's not 100% sensitive. Sometimes you can see a fibrous strand or an adhesion, and you mistake this for a vegetation, or sometimes it's negative, but this does not exclude the presence of device infection. Yeah, this classical vegetation of the artery lead. The guidelines also mention the use of the PET scan. It's very important. We have seen patients who have recurrent bacteremia, TE negative, blood culture is negative. You don't know what's going on, but once you do a PET scan, as you can see, there is a hot spot in the uptake with the DFG material in the intraventricular part of the lead, denoting that there is an ongoing device infection. This is the evidence of what we call the latest European guidelines. The management. The management is actually literally and truly is in your hands. Prevention is the gold standard. It's important to note that a pair of gloves is not much more expensive than a system. So using the simple hand hygiene and aseptic techniques, using maximal barrier precautions, making sure your gloves are work perfectly, you do not touch anything, your field is sterile. Some of these interventions, pre-procedural, intra-procedural, and post-procedural. Pre-procedural that the guidelines dictate that you have to, it's advisable to clear all possible sites of infections like dental or whatever 2 weeks prior to insertion. Antibiotics to be given 1 hour before the procedures. Inside the field, it's important to limit the personnel inside your lab cap, maximal barrier procedure techniques, secure your bleeding sites, and post-operative, not to remove the post-operative dressing until the post-operative day 2, and instruct the patient or not showering or removing the dressing or manipulating the pacemaker site. And now there are some talks about nasal screening for health professionals for MRSA carriers. It's important to not just put betadine on your wound site. It's important to do a friction scrub. This is an electron microscope image of the skin showing that 80% of the resident bacteria lies in the first 5 epidermal layers. So unless you do a real friction scrub, you'll still have contamination for your proposed sterile site. That was a study comparing the minimal precautions done and the maximal precaution. The rate of infection reduced up to 6 times if you follow the simple stuff. This is again the European guidelines giving antibiotics as a class 1 hour before the procedure, and eliminating the, as we said before, the possible infection sites 2 weeks before. This is a multivariate analysis of 7 trials, comparing giving antibiotic prophylaxis versus not going antibiotic prophylaxis. And as you can see here, there's a marked decrease in the rate of early complication like swelling, erosion, or generator pocket infection when you give antibiotics 1 hour at least before the procedure. Lately, the FDA approved what it calls a bioabsorbable antibacterial envelope, as you can see here. It surrounds your pacemaker. It makes sure that if by mistake your pocket has got some kind of contamination, this prevents it, protects your pacemaker, protects your leads. This is a study done on the efficacy of that newly developed envelope with patients that have 2 or 3 risk factors for device infection. As you can see here, the blue line on the top shows the patients who had the newly antibacterial envelope, and the black line, the patient did not. Usually and simply, if you don't have that, we sometimes off-label put, if your patient has 2 or 3 or more risk factors, you can put antibiotics locally in your pocket. We use a penicillin or gentamicin or whatever that can do the job as well. Concerning the treatment is so simple. Only you have to remove your system. Now it's class 1. If you leave your system, the rate for long-term or 30 days mortality increases to the double if you leave it. And get antibiotics pre and post. For the duration, it depends. There's an algorithm from the guidelines. Depends if your blood cultures are negative or positive, if your TE has got vegetations or no vegetations, and the duration rate between 7 days and up to 6 days if you have a complicated lead vegetation plus a positive blood culture. Now, how to remove your system? Will you go for the surgery or the lead removal techniques? Percutaneous. It depends on the center and operator experience. The facility requirements to get the proper tools. If there is an available cardiosurgeon on stand, if your patient has an anomalous placement of leads through an artery, whatever, you have a complication of perforation, then you will opt for surgery. If your patient is not suitable for surgery for any like sepsis or septic shock, then lead extraction technique will be more convenient for him. The guidelines also mention that as a class 2A, if your vegetation size is more than 2 millimeters, 20 millimeters, it's better to go for surgery. Also, mechanical and local complications like an abscess or prosthetic valve is preferred to for surgery as well. Here's the guidelines and the evidence, as we mentioned. And lastly, this is a patient. He came to our outpatient clinic. He had CRT implanted 3 years after a break from the DDT 15 years ago. And apparently he has neglected his device. I don't know how this happened, but obviously there was an opening, the leads got out. He took care of the leads. He took a betadine, was cotton every day, and kept it until somebody told him, no, you should see somebody. So he came to our clinic. He did a TEE. There was a vegetation, 3 vegetations, I think 15 millimeters. Blood cultures were negative. He was already on antibiotics. Unfortunately, he went to a place before he came to us, and they didn't have the tools. They tended just to do a manual traction of the leads, and he ended up crowding the 3 leads in the right atrium. Not only crowded, but I'm sorry to have the laser, but if you see here that there's starting to be an avulsion of the right ventricular and the left ventricular leads. So the inner coil is actually exposed. So that was a challenge, because if we started to do the extraction procedure, if the tip of the leads are left inside the heart, you did nothing. The lead's infection is inside there. This is the tool used to hook lead extractor, and the needle I snare for the tip. Unfortunately, I don't have the video. Sorry. This is procedure. And luckily we were successful to get the atrial and left ventricular entangled together. You can see the vegetation over there. And we explanted every bit of the whole leads, and the patients are implanted on the right side after 6 weeks of antibiotics. Everything went fine. And this is the right ventricular lead. You can see the fibrosis. And, thank you.